Right, well, I think we will get started. I think you can't see me because I'm screen sharing with the seminar slide. But my name is Megan Passy. I am the Director of Research here at the UCRH in Lismore. And I'm just doing the introductions today because Jodie normally does the introductions, but she is one of our presenters. So I'm taking her place. Now, before we begin, I'm sure there will be a few people coming in slowly, and but we will get started. So before we begin, I would like to acknowledge the traditional owners and pay my respects to elders past, present, and emerging. In Lismore, we're on Widjabul country of the Bundjalung Nation, and I can see there's people coming in from across New South Wales, and I'd like to pay my respects to elders and the traditional custodians of all of the countries on which we are gathered today. Just some housekeeping for this session. We are asking everyone to keep their microphones muted apart from the presenters. And I would also point out that the seminar is being video and audio recorded, so if you do have your microphone on, that will be picked up. So please do try to remember to keep it muted, except if you're asking a question. And we will do questions at the end of the presentations, not sort of interrupting the presentation as we go. So today's seminar is by Ross and Jodie Bailie, but I do want to put a shout out for the next seminar, which is on the 19th of November. And that seminar, we're presenting findings from the DAPHNE study, which some of you may have heard of before. DAPHNE stands for Diagnosing Potentially Preventable Hospitalizations. And this is a large project that we've done over 2 rural sites and 1 metropolitan site, and looking at the factors contributing to preventable hospitalizations and just assessing how preventable they really are. So that presentation will be by myself and Joe Longman, my colleague here at UCRH. But today we've got the presentation by Jodie and Ross Bailie. Jodie is a research fellow here at the UCRH and involved in a number of different projects. And she's got a particular interest in access. And Ross is the Director of Research, he's the Director of the UCRH, Professor of Public Health and Director of UCRH, and has a long-standing program of research looking at primary healthcare. So I'd like to welcome them both to present today, and we'll be talking about a framework to evaluate and understand access to healthcare in the Northern Rivers. Now, I've just realised that I didn't click through the slides as we went, but I'll just go through them slowly now. So keep yourselves muted. We are recording, and there will be time for questions at the end. The next presentation is the 19th of November, so please do join us for that one. And this is the presentation for today. So I will stop sharing my screen and hand over to Ross and Jodie.
Great. Thanks, Megan. I'll just organise the screen share here, so if you can just bear with me for a moment. Is that the single slide?
You had single just before Jodie. So
okay, great. Thank you.
Yeah, perfect.
Great, thank you. So Ross, I'll hand over to you.
Okay, great. Thanks, Megan, and thanks, Jodie, and also to acknowledge the traditional owners of the lands on which we all live and work and pay our respects to elders. I'm going to get started by talking a bit about the work of the University Centre for Rural Health, and the reasons why I'm going to spend a bit of time on this will, I hope, become clear as we get into the seminar. But the mission of the UCRH is about rural health education, research, workforce development, in order to address the disparities in health between people living in rural compared to metropolitan areas. We're funded by the Commonwealth Government to do this primarily through our health workforce development programs, and these include providing rural health training and experience for students in a range of health professions, including medicine and allied health, supporting ongoing professional development for health professionals in our region, including development of career training pathways for early career doctors and other health professionals, and then encouraging and supporting young people in our region to consider careers in health. We also have an active research program that is focused on rural health, particularly health services and health systems research, health equity, new models or approaches to care, Aboriginal health, mental health, environmental impacts on health, including climate change, and in rural health education. So this means that we've got an interest in research on a wide range of the most important health conditions that affect people living in our region, rather than being interested in any particular disease or particular population group. And we're interested in people of all ages rather than on people of any particular age group. And importantly, we've got to focus on people who face significant challenges in terms of health status or access to healthcare. So we aim to conduct our education and our research at the UCRH in ways that contribute directly to improving health service or health care. So it's very consistent with the sort of current talk about service-based learning or work-integrated learning. And so by doing this, we aim to directly benefit communities in our region. So there are many factors that contribute to the disparity in health between rural and metropolitan Australia. Some of the most important of these are largely outside the primary responsibility of the health system or health services. One of the most important factors, to the extent that it can be seen as an individual factor, is partly within the responsibility of the health system, is access to good quality healthcare. So this concept of access is really vital to how we go about doing our work and how we understand it. But this concept of access to care is nuanced and multifaceted. And so the aim of this seminar is to examine the concept of access to care and discuss the main barriers to access in relation to priority healthcare needs for people in northern New South Wales, and to explore what this means for how we at the UCRH can work with local communities and local services to improve access to care. Understanding the factors that restrict access for people living in specific locations or for people in particular population groups, especially marginalised groups, or for people living with particular health conditions is vital to developing health programs or strengthening the workforce in ways that will most effectively improve access to care for different groups who face different types of barriers to accessing high quality care, or for whom there are different reasons for why they have difficulty getting the care they need. So we expect that the discussion from this seminar will be helpful in guiding and refining our education and research programs at the UCRH. And we hope you find the seminar interesting and stimulating. So Jodie is going to take us on now with doing a short exercise about what comes to mind when people think about access to care. And so we're going to use this little exercise just to encourage people to use the chat function on your Zoom. So over to you, Jodie. You're on mute, Jodie.
Am I off mute now? Great. Oh, boy. Thank you. So we've all been using Zoom probably for a while now, so we probably know how to use the chat function a little bit, but it's just for those that may not be familiar, it's just down on the bottom toolbar of Zoom there, you'll see a chat function. So you just click on there and it will pop up. So what we'd like you to do is to think about what are the words that come to mind when you think of access. So what are the things that top of mind that come to you when you're thinking about access to primary health care. We'll just allow a few moments for that, for people to.
It's great, all these suggestions. It's,
Yeah.
we really appreciate this contribution.
Yeah, that's great. Cost, transport. Yeah. Well, I thought that most of you were going to write that it's mainly an attribute of services. But Ross, can you see the things that are coming through?
Yeah, so yeah, I mean that's great. Most of them are kind of attributes to services, but there are some interesting ideas there that reflect attributes of communities and people and the interaction. So I think we should move on.
Yeah. I like someone's written person-centered, because we're about to present quite a person-centered framework. Okay, so we know that access is central to how well health systems perform. Though despite the centrality of this concept of access, there is still a lot of ongoing debate about how we actually define access, and also the factors that influence access. So here on the slide, you can see that access is defined as the opportunity to have healthcare needs fulfilled. So as we saw from that exercise, yes, a lot of people did actually put in there that access is they saw it perceived as an attribute of services, but also people were putting in comments around other factors such as availability of services, and also things from more of the, about people's ability to access services. But access obviously goes further than just the availability of health services. And as shown on this slide, you can see that its access is really resulting from that interface of the characteristics of people, households, social and physical environments, and the interactions with the characteristics of health services, organisations and providers. So access is really reliant on how well healthcare resources, or the supply side, interact with the person's ability to obtain and seek care, so the demand side. So access is achieved through the interactions of those two sides. So in 2013, Levesque and colleagues proposed a framework which identifies that access is achieved through the interactions of both the supply and the demand side of determinants. So on the supply side, care needs to be approachable, acceptable, available and accommodating, affordable, and also ultimately appropriate. On the demand side, these interact with demand side dimensions, and these demand side dimensions are related to people's ability to perceive the need for care, to seek appropriate options, to reach health services, also to afford, so both indirect and direct costs, and also their ability to engage with service providers. So the access framework that I've put on the slide here, I have simplified. So Levesque's framework has a number of other elements to it. And so this slide has been adapted for this presentation. But what this framework really shows, or makes clear is that it's the interactions between both the supply side and the demand side that enable access. So with each dimension, there are a number of factors identified. So for example, if you look at the top left hand on the supply side, approachability, you can see approachability relates to various elements such as transparency, information regarding available treatments and services, outreach activities that could contribute to make the services more or less approachable. And then on the bottom side of the framework there, under ability to perceive, you can see that the factors there are determined by things such as health literacy, knowledge about health and beliefs, and also related to health. So knowledge is related to health and sickness. So if we're going back, what we wanted people to do now was to feel free to turn your camera on, despite, I'm sorry, I gave Megan instructions that we were going to ask people to, we're going to hold all questions off at the end, but we are hoping to create, some sort of dialogue. I guess what we're hoping for you to now is to reflect on and think about the comments that were made within the chat function around what we think about access and how they relate to the different determinants of access that have been put up here on this framework that's been proposed by Levesque. So feel free to turn your microphones on. Do you have anyone have any initial thoughts about this framework?
Yeah, I can kick off, Jodie, but just, I think one of the other interesting things about this framework is that something like cost, which came up in the chat function, actually has, supply and demand side functions. So cost is obviously an issue, but the ability to pay, so how much you can pay is on the demand side. And so cost has kind of dimensions to both sides of the framework. And the way that Levesque developed this framework was almost as if these things operated in pairs. And we don't think that's it's not strictly true, but in general, that's kind of how the framework is meant to be understood. And I think that the cost dimension is a good example of where you can see both sides.
Yeah, Edda from Acorn Northern Rivers. I think what's missing here is for service users to be able to feed back into the service when there is an access issue.
Yeah.
Because obviously we are all learning as services how to remove barriers, especially for more marginalised community members. But there's just nothing in here about how when people experience a barrier, how they're able to feed that back into them. It must be another feedback loop that comes back in from the side or somewhere.
That's a great comment. Thanks, Edda, because what we're interested is hearing from you guys about what do you think, how does this help you understand or think about what do you see as the big barriers to access that we face or our communities face in Northern New South Wales, and what do we need to learn more about those things in order to improve care or how, design our programs or feed into the development of those programs.
Emily here from Broken Hill. One of the things that we're working on out here is looking at bringing the theory of candidacy together with the theory, the theory of access together with the theory of candidacy, which reflects on into the service and more of the personal experience and how people access and can access services. As you were saying earlier, a lot of times our thoughts go to what the services are doing, but candidacy looks at vulnerable populations and how they can or cannot access services and how we can think through that a bit differently. So we're putting together some work on that.
So thanks, Emily. So where do you think that would connect into this framework? Do you think it kind of is in general, or there's specific domains within this framework that you expect that work to connect with?
That's actually what we're working on. We're bringing these Levesque, my work, and Dixon Wood's work on candidacy together, and looking at how to bring those into the same space.
Other comments or suggestions?
It's Val from Ballina. I have a foot in both camps because I was allied health provider for decades, and now I have young onset dementia, but I have a pain syndrome. And if it wasn't for my package, there's no way that I'd be able to afford the amount of care that I need to keep me out of pain, because I've got a central pain-driven syndrome. So I have regular acupuncture, myopractics, and osteochiro. I know that's peculiar for a physio to be going that way, but they're the hands-on treatment that actually keep me out of pain. And if I'm out of pain, I don't ideate to self-harm, and my brain is clear, and I can interact in things like that. I've just come off a DAC conference because I'm an advisor to Dementia Australia. So part of me is just listening, but I wanted to interact to say that I had to be my own best advocate because I knew what I needed to stay well, but that's very rare. So you also need people to be able to think outside the square to know what to offer. And I've also been out at Nyngan, so I really identify with the person at Broken Hill in terms of what facilities are available. And often, because I was a sole physio at Nyngan, and you know, if I didn't get people better, well, there was nobody else to go to other than travelling 160 mile or more. So that's me.
Yeah, thanks for that, Val. I think you've actually pointed to a few things that I think we could connect into this framework. And yeah, it's interesting how that relates to personal experience. Any other comments?
It's Megan here. I just want to follow up on what Val was just saying. It's about how these things can vary too. Val was talking about how her ability to cope varies depending on how well the pain's being managed. But those things all interact. That ability to cope is all interacts with some of these other things. So your disease severity and your disease, the point in your disease, if it's a fluctuating thing, can also interact with access. And I don't think that's captured here in the...
I wonder if it's picked up in that the dimension around ability to engage.
I guess it's about flexibility. It varies, though. I guess that's what I heard from Val, how that varies.
Yeah.
And so that these things aren't constant. These ability sides are not constant.
Yeah. Okay.
So Megan, that's an interesting comment, because I think that dimension of it could be picked up in that appropriateness domain. So clearly, what is appropriate for different people with different conditions at different times changes. And so I think, the issue on the supply side and for health services is how do they ensure appropriateness in terms of different needs at different times.
Hi, it's Natalie from Lismore speaking, and I was just working this morning looking at shared care, particularly in relation to HIV, but I think it's a common issue across a lot of services in that there's often duplication. So there's multiple services trying to supply the same thing, and there's not coordination of that care. So there's waste in the system. So, you know, I guess when we think about access, it's not always about just providing more service, it's providing that service without waste.
Yeah.
Yes, and that's where I agree with you, and that's where the component of awareness, I think, comes in on the side of the service, and knowing what gaps are they actually there to fill. Are there gaps, or are we duplicating services in spaces?
It's Jenny here. I'm from Lismore as well. I think I was thinking along these lines, and thank you to the last couple of people who, I guess what I have seen as a practicing physiotherapist is that there's such fragmentation in the current system and a lack of integration. And so even if I'm doing my very best, I might not know what other services are being provided, and we might be overlapping, or we might be absolutely duplicating and the person's missing out on something else. And so I think it's, what I can't see on this framework is, and I don't know, I don't have the solution for where it fits, but my thinking is that that coordination and integration across the supply side to make sure that the person on the other side is accessing what is exactly right for that person, the person-centered thing. And I think there's still a lot of silos there. I'm just not sure where that belongs or how to address that.
Yeah, it's interesting. Possibly, again, I'm just thinking it could fit under information, under approachability. So services, you know, how much information are they putting out about the type of service that they have available? So it could fit there, and also that around that appropriateness, and there's under their coordination. At the end of the seminar, we'll give you the reference for the full paper. That's and it's open access, so it's free. You can log in and get a copy of the paper. And they give much more detailed descriptions about each one of these dimensions. But the framework, you know, it's really important for us to think about how that would work for us in each one of our circumstances.
Sorry, it's Valshaki here again. I would like to see somewhere that the providers of these services are actually being educated with the latest approaches and who to go to, because unfortunately you bang your head against so many times the people are out of date, particularly with young onset dementia and what can be provided, you know, and even to talk rehab. You know, other people with deficits get rehabbed. Dementia, you just put in a box is too hard, or you're not worth it. So, but the education, I can't see where education is here. Yeah. So I think it's absolutely imperative that people are educated, but the education is continuing.
Yeah, that picks up also on that first point also, doesn't it, that was made around, you know, how feeding back into services.
I think it's also picked up in, you know, in that first pair, the approachability versus the ability to perceive. So clearly education needs to be appropriate for different people depending on their understanding of the system, and so it needs to be tailored. But it also services need to be transparent about the services they provide. And you know, I think it's, you know, what's coming out of this conversation is the connections between many of these domains. They're kind of not discrete. They often interact in different ways. So Edda, I think you had a comment.
Yeah, I do. And I really love this model. I want to say that it's very useful as a service provider to be breaking this up. One thing that's not sitting me with is the individualistic nature of the service user, the ability to. It's really placing the onus on the individual rather than looking at the systematic structural barriers to health services, especially when you're looking at social values. there's no ability involved. They're actually systematic barriers, and especially in a white supremacy country like Australia, they're barriers that have been built in intentionally into our society. So I think it just doesn't sit well that it always be placed on the individual, like the individual is responsible for the barriers. I think just getting rid of the word ability, it's a very loaded term, and try to use a word that kind of takes into account individual barriers, but also structural and systemic barriers to health services.
Now that's interesting, because I guess maybe it's just because of the way I think about these things. I see, a lot of these things actually relate to systemic challenges rather than challenges for individuals, or at least the solutions lie in systems change rather than trying to change individuals. So it's interesting that you saw the framework in that way. So
it's just that word ability.
Yeah.
Because we usually say, I'm able or I'm not able. I have the ability, I have a disability. It's not always offered in an intersectional framework.
Yeah.
That word.
You would just interfere with his alliteration, that's all.
Well, that conversation's been really helpful, and we will continue on having these conversations throughout the afternoon. So as as we've started to sort of think about, we've got this access framework, and how could we use this framework for our work in the Northern Rivers? So just put up some ideas here. So this framework could be used for trying to understand which type of barriers may be important in which locations, to assess different barriers to access for different types of services for people living with different conditions, evaluation of programs that aim to improve access. So that's how we've used it before. Designing programs that help to improve access. So if you're looking at designing a program to improve access, to use that framework to think about the different determinants. Another way that the framework could be used is around, in terms of assessing policies. So what are the different policies that have been designed to improve access and the extent that they are? And also, of course, for student projects, but I'd be interested to hear other thoughts about how you might be able to use something like this in your workplace. Or have I covered it all?
I think it's Jenny again from Lismore. I think at the moment, because COVID forced us to go online and use telehealth, that's been an interesting one for increasing access to services that, so at the moment, the physio students and actually all of the allied health students, not just the physio, I'm talking that because I just finished with them half an hour ago, but the other allied health students as well are providing services via telehealth. And so that means we are doing a bit of a hybrid where we're going into placement sites that we used to go to, but we've also been able to open up and offer the services, it's the services, even though it's an education opportunity, offer services via telehealth. For example, on every second Tuesday, we go to Kyogle, and people that live on farms out of town where it's quite difficult for them to come in for physio, it's about hour and a half or 2 hours transport for them. They see us via Zoom. And so that sort of just happened because of COVID, but we're going to keep it on after COVID finishes so that people who are geographically removed, but then of course, that leaves out a lot of people that aren't tech savvy. But that's one example of some people that were unable to access because of distance, who are now, but it doesn't help people who are not tech savvy or don't have good internet.
Yeah, that's a great example. And also just, in terms of thinking about how you would extend that program or embed that program, thinking about the different dimensions and to improve accessibility.
Jodie, we've got a few comments coming through in the chat function as well on this. So, you know, I encourage people to look at the chat function generally because there's some good comments in there. But on this point in particular, people are suggesting education and training of our current and future workforce could also be used for consumer engagement, including clients, carers, community groups. There's a comment from Emma Webster about currently using the framework or used it recently to perform a framework analysis.
Yes. Yep.
And from Eda suggesting community capacity building activities such as increasing health literacy, knowledge and confidence in navigating health systems and supporting others to navigate health systems, empowerment and social change processes to address structural and access issues. So there's some good suggestions there.
We might move on. So hold all of those interesting ideas. So over to you, Ross.
Yeah, so thanks, Jodie. So clearly, what an important thing is that we should look at what data is already available, or that might help us understand access issues. And there is some useful data for Northern New South Wales. One important factor on the Jodie, if you move on to the next slide. One important factor on the supply side of the access framework, and this came up early on, I think it might have been the very first one, is geographic location. And so this can be measured as distance from a service centre, such as a city or town. And this modified Monash model is used, of measuring remoteness or rurality, is used by the Australian government to define whether a location is a city, rural, remote or very remote. And the model measures remoteness and population size on a scale called the modified Monash scale of 1 to 7, with 1 being a major city and 7 being very remote. So this scale tells us about an area according to geographic remoteness and town size. And areas classified as modified Monash 2 to modified Monash 7 are rural or remote. And people living in these services are recognised as finding it harder to get healthcare they need, and accessing doctors or other health professionals can take longer and cost more. So here in the Northern Rivers, you can see we have a range of classifications according to this modified Monash model, with right up in the northeast corner being modified Monash 1. But noticing that the towns of Casino, Byron Bay, Yamba are categorised as modified Monash 4. Everything that you see in green there is categorised as modified Monash 5. So, a very large part of our region is at that kind of really rural end of the scale. And next slide, Jodie. So clearly, it's obvious where that fits into the framework. So we'll keep going, Jodie. So the other valuable data is, comes from PHN, who have done these needs assessments in the region. So this is about again, on the supply side, is the availability of health professionals. And one way of measuring this is the number of health professionals per 1,000 people in the population. And clearly this is closely related to geographic location, but isn't necessarily exactly the same as geographic location. So this data comes from the North Coast PHN fact sheets for Northern New South Wales. And they're based on data from various official sources, including the ABS, Health Statistics New South Wales, and local community surveys. And they're a good source of local information, and they're freely available on the web. So the data on this slide has been extracted from the fact sheets, and it shows that access to allied health professionals, or at least the number of allied health professionals per 1,000 population, I've just made it easier to read by shading the cells according to sort of a ranking scale, and so with the darker shading shows the sort of the smallest number of health professionals per 1,000 population. So you can see clearly from this that Kyogle, Lismore, Richmond Valley, Clarence Valley LGAs are the ones that are least well served by these particular health professionals, which are the ones that we kind of have consistent data on across all of the LGAs. But there isn't data for most other health professionals in these PHN fact sheets. So that sort of highlights an area of where we kind of need better quality data immediately. So if you keep going, Jodie. So similarly, but it's turning to, it's not just the availability or the numbers per 1,000. You can also assess availability through the percentage of community members who report experience with difficulty accessing healthcare. So that's just kind of people's experience rather than just counting the numbers of health professionals. And so again, the depth of highlighting in this table shows that it's really the same for LGAs, where these community surveys are showing that people in those locations are reporting greater difficulty with accessing these particular health professionals. Keep going, Jodie. The PHN data, they also gather through their community surveys, gather data on what people report as the barriers for seeing, for example, a GP. So can't get an appointment when I need it. So, you would have connected this with the framework there. Appointments or availability of appointments was was what was in the framework. Too long to wait for an appointment. So still about appointments, but it's a different kind of different issue around appointments. Cost too much. Public community transport is too limited. They're not open when I can go. So it's an availability issue. So go to the next slide, Jodie. So you can see, just reflecting on those things that people talked about, the commonly reported barriers, this kind of on a quick scan, this is kind of what it connects to, those issues connect to in the framework. So next slide. So similarly, we need to think about when and I guess this point was made in some of the discussion, is that we actually need to understand what are the big issues for people in communities and what are the most important health concerns. So it was, I think that discussion about I think Natalie was talking about, what's available and how do we make sure that we're making most appropriate use of resources. So clearly we need to be directing our resources to the areas of greatest need or the biggest health challenges. And so these are the list of things that people commonly reported as their greatest health concerns for people living in Northern Region New South Wales. And the top three were pretty much the same for all of the LGAs. The top three were pretty much the same. The exceptions were in Richmond, where they said, access to healthcare was in amongst the top three. And for when they did similarly, they looked at the data reported by older people, where diet and exercise interestingly came up in the top three. And the data from Aboriginal and Torres Strait Islander people, family violence came up in the top three most serious health concerns. So, understanding what are the big issues for people, what are they worried about? We need to think about that in terms of what do we need to do to improve access. Next slide, Jodie. So the economic disadvantage, that challenge is really understanding some of the nuances of the supply side issues and how to get a handle on those. There's relatively little data available. It takes greater effort, but economic disadvantage is an important factor in people's ability to access services, kind of as a general measure. And the Australian Council of Social Services uses household income adequacy as an important overall indicator of economic disadvantage. So for the more technical people, this household income adequacy is the percentage of people who fall below 1/2 of the median household disposable income after taking account of housing costs. So thinking about this in relation to some of those earlier comments about, are we just thinking about individual issues or systemic issues? I think this is clearly it's sort of getting at some of those systemic issues. So this map shows the overall estimated rates of people living in economic disadvantage for northern New South Wales. So again, you can see the towns of Lismore, Ballina, Casino, and the LGAs of Kyogle and Clarence Valley, including the towns of Grafton and Maclean, are the most affected by economic disadvantage. And some of the areas of relative disadvantage, with some areas of relative disadvantage in Byron and Tweed LGAs. So these data can be taken down to quite a small area, quite a small geographic area, to get that valuable in terms of really understanding the small area variation. The most seriously economic disadvantaged groups in northern New South Wales, according to these data, are right here in Lismore. It's not that clear because it's obscured a little bit by the label of Lismore, but that darkest shade of red is between 20 and 30% of people living in economic disadvantage, and there's some suburbs within Lismore where that's the case. So this economic disadvantage may be related to a range of factors in both the demand and the supply side of the framework. So it's worth having a bit of discussion about what those may be. What do people think about how the sort of measures of economic disadvantage connect into that framework?
Jodie, it's Megan here. Would you be able to put the framework back up, which I realise it's quite a few slides back, but it just might help us think. Yeah, that'll do.
Yeah, because that's what I was noticing. I was noticing health professionals per population and the percentage of community members who reported difficulty accessing a health professional, and they're not matched up. Like there's less health services in Byron, but they're finding it easy to access health professionals. So that shows there's an economic aspect to the access issues. It's not just because we don't have enough issues. I think just those two slides side by side are tell the picture, tell the story clearly.
Ross, you're on mute.
Oh, sorry, Jodie, perhaps we should keep going because we want to make sure we've got a bit of time at the end. So if we keep going to, yeah. So the question is, what more do we need to know about the priority barriers to access to important health services for different groups? And what I've done here is I've actually just listed some of the groups who we know from local experience have face particular barriers to access. So people living in aged care facilities, youth, young children, Aboriginal people, people living with disabilities, LGBTIQ people who are homeless or in transient housing. And I'd be interested, we could have a discussion about whether there are other sort of very important groups who are missing for that. But maybe we can move on to the general access framework again, Jodie, and think about, reflecting on the groups that I've listed there, but also any other groups that you can identify as being, having important difficulties with access. What should be the priorities in our region in terms of access to care? based on what you've seen in the data, but also your own local experience?
Hi, I'm Kathy. I'm a social work student and I'm doing my placement in a nursing home. One of the things that I've seen is that cognitive decline makes it very difficult to not just to access help for people, but to sort of support that. So for example, I'm working with a man who constantly doesn't have his hearing aids in, but then when he does have his hearing aids in, he tends to put them in his pocket, or he might drop them in the bin accidentally or something like that. So that means that then he doesn't have hearing aids again. So, you know, that cognitive decline can be a huge factor.
Yeah, thanks, Catherine. I think what you've said actually really highlights the sort of interaction between the demand and the supply sides for people.
It's Kelly here. I'm looking and I can't see where issues of safety fits. I'm thinking particularly in relation to violence against women and those sorts of issues, that it can be really real barriers and to accessing health services. Where does that fit in here? And they weren't in one of the groups that were on the previous slide.
It might fit, Kelly, in under acceptability, because that really relates to, I guess, cultural and social factors. And so, for example, if a service is being culturally appropriate, so it may fit in under that domain.
It also could fit under availability. I mean, if they're just not the availability of the right sorts of services for people for women who are in those sorts of circumstances. Any other suggestions? Yeah.
The other thing that I was just drawn to was on the supply, on the demand side, is that ability to seek. So, you know, women may not have, in that circumstance, may not have the ability to seek or, you know, to choose care.
Yes, I guess to me it's not. I can see autonomy, I guess,
yes,
but for me it doesn't really sit very easily there. It doesn't really recognise what's going on and the obstacles to them accessing, and so I mean, unless you like autonomy for me doesn't. That isn't obvious in that for me. It doesn't speak to that.
So Kelly, what do you, from your experience, your perspective, what do you think are the main barriers to access for the right sort of care for women in the sort of circumstances you're talking about? What do you think the main barriers are?
In the context of, there's a number of things that do come in under, like, for example, access to their own finances. There's no control over that. In some circumstances, it's not safe for them to seek services. They may not be and even if they can get out of the house, for example, and then can get to a service, there is like a service might be confidential, but particularly in more rural communities, the confidentiality from a community's perspective isn't always there. And as we know, when women are seeking services, and are considering, you know, seeking services that give them options and provide options to them, can increase their vulnerability and increase levels of violence directed at them. So that it's quite a complex mix.
Yeah, I mean, those are really great examples, because it gives us some ideas about how we need to think about, for example, that ability to pay domain how does that apply to people in particular? So you said women in these circumstances may not actually have access to the money to pay, which may be a factor in their ability to pay. But understanding that in relation to women in this particular circumstances is important. And similarly, that ability to seek, you said they may not be able to safely be able to go to those services. Yes. The constraints on their ability to seek out those services may be quite nuanced, but, would fit under, what is the community, the culture in the community and the degree of confidentiality and the extent to which people can go and find the right sort of services without fear of somebody letting somebody else know that this is what they're doing.
Correct, and then the repercussions that come from that. Yeah.
Hi, Sarah. I wanted to bring up another topic which is a little bit complex. Thinking about Kogel, where they haven't had an access for a service for so long, people don't even know what that service is, so they don't actually advocate for the service, if that sort of makes sense. So if you've never had a particular service, you don't know that you need that service, and other health professionals maybe don't advocate for that service. So I know it's a common one. You brought up OT, and they haven't had an OT in Kogel for 10 years. So talking to the community out there, they're like, well, we don't really even advocate for an OT because we've nearly given up.
Yeah, it's a great example, Sarah, and I think that kind of fits into that ability to perceive things. So the health literacy thing is about, what is their knowledge and understanding of this, of the conditions that people may be having, but also what are the types of services that should be available to meet those sorts of needs. And then related to that, what are their expectations regarding the availability of those services? So first, people may not even know much about the conditions they're experiencing. They may not know much about the sort of services they need that could be available to help them, and they may have very low expectations of being able to access those services. And I think that is interesting, because that then connects through to the box on the bottom right about empowerment and information. How do we enable people to get greater understanding of their conditions, the services, and empower them or enable them to advocate for the availability of those sorts of services.
And then funding on top of that, because often where there hasn't been a service, they lose the funding for that service. So therefore there's nearly a limitation, and that happens across quite a lot of different services and areas as well.
Yeah. Okay, look, we're running out of time, but this has been a really good conversation from my perspective, and hopefully you've found it stimulating and interesting. Jodie's just put up the reference to the framework for those people who are not aware of it. Clearly, there are some people in the audience who have actually got quite a bit of experience in using this framework, and I presume you found it useful, because otherwise you wouldn't be using it. And then we've got an example of a paper here where we've applied the use of the framework to the evaluation of a national program in Indigenous health. So it's a kind of worked example. But I think, just to go back to the point that I started with, where the work that we do in the UCRH is really meant to be local and applied, and we like to be able to deliver our programs and do work in a way that helps improve understanding and the quality and availability of care in our region. So, people kind of have ideas about priorities and key issues, and particularly if you've got an interest in getting students to work on projects that could help us understand, improve the understanding around specific things, then we'd be really keen to hear from you. And So Jodie, did you have anything you wanted to add to wind up?
No, just to say, I guess just to reiterate the point that, you know, measuring access is a complex task.
Indeed. Well, I think we might wrap it up there. I think it's been a fantastic conversation about access and trying to unpick it and understand it. And what I'm hoping is this is just the beginning of the conversation, and that we can all continue to discuss these things and find ways to progress some work around access, because it's clearly a very critical issue for our communities. So finally, just thanks to everyone for coming and participating and being a part of it. And we hope to see you next month, 19th of November. Same time, same place.
Thank you, Megan.
Thanks a lot.
Okay, thanks everyone.
Thanks everyone.